What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
Good morning, everyone. This is Dr. Zach Baker of Rehab to Perform, and this is part of our monthly journal article review series that we do with our sports residents here at the R2P Sports Residency, and we are coming down the home stretch of the residency. Christian is with us today, and he is going to be moving on to the next part of his career, going into the professional baseball world within the Houston Astros organization. So this will be one of the last couple times you hear him on this podcast, at least in this capacity. I'm sure we'll bring him back in the future at some point as well to get a little bit of updates on what he's getting into in his career. But with this month in the residency, we covered pre-participation screening. And this is something that I think in the sports residency is a pretty unique experience to go through. And Christian was fortunate enough to be able to do this with one of the minor league affiliates here that we have in the city of Frederick, where he went over there with our other sports resident, Bami, a couple of our PT students, physical therapists, and most importantly, our athletic trainer, Megan Gray, who is kind of spearheading this whole thing and leading the event for us. And they got to go through pre-participation screening and physicals with the baseball players over there. And Christian, do you mind talking to us a little bit about the article that you chose for us? And I'm pretty interested to talk about this one because I do think we talk about prehab and all these other things that we can do from a quote-unquote injury prevention standpoint when we talk about ACL injuries and ankle sprains and more of your orthopedic conditions. But we need to think big picture sometimes, and we need to make sure that we're ruling out other red flags and making sure that individuals are even safe and appropriate to begin participating in the sport.
Yeah, for sure. So the article I found is called "The Value of Screening for the Risk of Sudden Cardiac Death in Young Competitive Athletes." And I chose this article because, I think through all of the education leading into residency, through the emergency responder course, a large percent of that deals with how to deal with these sudden cardiac events on a field. Unfortunately, kind of in the news and in sports, we've seen a few of these in the last couple of years that have been televised and talked about a lot. And so it's something that is obviously very rare to happen, but when it does happen, it is potentially extremely serious. And it's kind of a high pressure situation there. I know there's been some talk in the past and some of the research about can these conditions be screened out prior to even participating in a sport. And so I found an article here that talked a little bit different just about can these things be screened out, especially in the youth population.
Awesome. And do you mind talking a little bit about just kind of the background, the setup? What was the nature of this study? Who was involved? Where did it take place? What was really the purpose of it?
Yeah, absolutely. So this study took place in Italy, in a small town in Treviso, Italy. And really the idea was to create a pre-participation screening examination for all youth athletes aged 7 to 18 who were interested in playing organized sports in the area. And so what they did is this organization created, with the help of medical professionals, a pre-participation screening exam that every individual or every youth athlete had to complete prior to being eligible to participate. This pre-participation exam consisted of kind of 4 different topics. One is a kind of a history, both personal and family history. 2 is just a normal clinical exam. I kind of attribute those 2 as to something pretty similar to what you would get at the general practitioner or primary care provider. The third part is a resting 12-lead ECG. And then the fourth part is cardiac stress testing. So each youth athlete underwent all 4 of those tests prior to being eligible to participate. If any came back positive or if there were any concerns there, they underwent additional testing, maybe with a 24-hour ECG, maybe a max exercise test or an echocardiograph. So that's kind of the way they screen these athletes. And really the goal of this study was to do a couple different things. One, what is the diagnostic yield? Meaning basically how many of these cardiac conditions can we catch in these populations by participating in this screening? 2, kind of what is the cost of these serial evaluations and what is the cost? What does it what is it costing us to diagnose these conditions? And 3, kind of what are the long-term outcomes, meaning are we catching these things and are we preventing these sudden cardiac injuries in the future?
That's pretty cool. And this was actually more in depth than what I would have imagined just going off of the title of the article. And it's pretty cool that they incorporated, they have the typical stuff, your physical exam, your personal, your family history. That's what I think of when I think of a youth athlete physical or a pre-participation screen. Going through the resting 12 lead and then also the stress testing, that's pretty cool that they were able to do this with this population. I believe that the youth athletes were ages 7 to 18 with this. So this is something that I envision taking place more in like the collegiate and professional environment, or only for people who during a physical kind of got red flagged, that they needed more of a workup. So to have all this as a baseline to work off of, I think is pretty impressive and pretty cool. With this, we talked about the primary endpoints, looking at diagnostic yield, looking at the cost of evaluations. That is important. And it's one thing where if we know what the gold standard is, assuming we find the gold standard, it's also assuming, is it even feasible? And I think just having these types of studies, having this type of data available, it at least gives you a starting point for some of these conversations and how can you scale this to other organizations or on a broader spectrum. And then obviously the long-term outcomes, are we even finding what we're hoping we can find? Kind of good segue into the next question. What did they end up finding? What were the results of this article?
Yeah. So just briefly on the baseline characteristics, the population was just over 22,000 athletes over the course of a couple of years. So obviously we have a very high N equals whatever, so 22,000. Additionally, one thing that I thought was pretty interesting is that those additional investigations, basically meaning that somebody who tested positive or there was an issue with one of their first 4 tests and required additional testing, was warranted in about 9% of all first-line investigations. So just about 1 in 10 individuals was then sent for further workup. Some of that further workup was negative, and it was just a blip, like a false positive on some of the earlier tests, but some of them obviously kind of transitioned into the diagnosis of a cardiac disease. One thing that was interesting is the reasons for those initial investigations or additional ones. About 2% of them were based on family history, and 1% were based on the physical exam, meaning that the majority of the ones that were sent for additional investigation were either an issue in the resting ECG or the abnormal exercise stress test.
That's kind of wild. So that's like 8 of the 10% came from those 2 tests that we just talked about, usually aren't even included in your traditional ones. So. Yep. Cool. And then moving forward, do you mind getting into diagnostic yield, cost analysis, long-term outcomes? What did they find with some of that?
Sure. Yeah. So the diagnosis of a cardiovascular disease was made in 403 athletes, or 1.8% of the total population involved. 334 or 1.5% were not associated with sudden cardiac death. So there were certain cardiac diseases that were not have not been found in the past to be leading to those sudden cardiac death conditions, whereas 69 of them total, or 0.3%, have been linked to sudden cardiac death. Ones that frequently are associated with that are maybe congenital heart diseases or ventricular deficits or maybe even cardiomyopathies. Diving a little deeper, of the 69 that had a cardiovascular disease that may have been associated with sudden cardiac death, only 30% of them had a positive either family history or abnormal physical exam. The vast majority of these people tested positive either through an abnormal resting ECG or an abnormal exercise test, stress test, which is kind of just what you alluded to there as well. Diving a little deeper as well, of the 69 that were testing positive, only 36% were found at that initial screening exam, meaning that the 64% or the vast majority were kind of found on repeat exams moving on. In the cost analysis, really all of this talked about is just the cost per diagnosis. So this didn't actually discuss on the cost that it costed that youth organization to hire the medical professionals to perform all of these tests. It just discussed on what the cost per diagnosis. So For a certain age group, for the younger age group, it was about $140,000 per diagnosis. For a little bit older, it was about $66,000 per diagnosis. Honestly, I think that's a little bit outside the scope of what we are talking about here in PT. I'm not entirely sure what the cost per diagnosis is outside of this setting, but it at least did kind of allude to that and highlight that. And then lastly, it talks a little bit about the long-term outcomes. So they followed all these individuals in the study for over 7.5 years, and they found that only one individual of the over 22,000 ever underwent a sudden cardiac death situation. And when they dove a little deeper and looked into it, this individual actually tested negative on multiple cardiovascular evaluations prior, meaning that all of the 69 individuals who came back as having a cardiac disease may be associated with sudden cardiac death. None of them ever underwent a cardiac event ever. The one person who did in the study actually tested positive through multiple cardiac evaluations. And when they actually spoke to the hospital about afterwards, they was actually unable to find a reason as to why that person underwent sudden cardiac death.
Interesting. I think you alluded to it earlier. The cost analysis is cool to look at. In this specific instance, it's tough to do much with those numbers, but the diagnostic yield and the long-term outcomes are really what we're getting after there. When we kind of get down to like the bottom line, the conclusion of all of this, it looked like things that we can take away with this was, of that large sample size, that 22,000 plus, about 400 of them who were asymptomatic came back diagnosed with some sort of cardiovascular disease, which ends up being 1.8%, almost 2% of the population, which that's significant in my opinion. And what that ends up alluding to or happening with, but I think just having the awareness that there is a population of individuals who are going to be participating in youth sports or high school sports or collegiate sports, that you need to be aware of what some underlying factors are that they're potentially dealing with and how that may influence risk factors moving forward. With this, it looks like they had a greater diagnostic yield with that older age group, which they had categorized as 12 to 18 years old out of that total 7 to 18-year-old population. And it was I think this is a big takeaway, greater diagnostic yield with repeat examinations and just, not the one and done, not just finding one quick screening tool and going from that. And I understand the logistics and the feasibility with, look, it's tough. You go to any high school in the area and you try to get physicals done. It's hard just to schedule them. It's hard to find physicians and medical practitioners who are are more than willing to do them, but just trying to fit them into their schedule and then trying to get schedules to match up, trying to do that in conjunction with when sports seasons start up. And then you get into what resources do we have at play to do some of these. So I understand, what's ideal versus what's probably going to happen in most situations. But I do think it's important to notice that the ones that were having a greater diagnostic yield were the ones that were getting multiple exams done. Less than a third of the individuals diagnosed with cardiovascular disease were associated with this based on some sort of family history or physical exam. And no athlete was diagnosed with cardiovascular disease with potential sudden cardiac death had ever had a cardiac arrest event. So when you look back at this study, Christian, were there any specific limitations that stuck out to you? And then after that, if you don't mind just getting right into what's our big takeaway from an application to clinical practice?
Yeah. So, I think two big limitations. First of all, I think you kind of alluded to it right there. It's the resources aspect. And this study did a really good job at kind of discussing that as well, and that organizations or areas that just have limited resources are likely not going to be able to replicate this pre-participation screening. This study luckily paired very, very closely with a local medical center who was able to offer cardiology resources for all of these individuals. Like you said, it's the pre-participation screening, especially for youth athletes into high school. Unfortunately, the money just isn't always there and the resources aren't always there. And so obviously that's a huge limitation for this study being able to be replicated out in the clinic. And then two, the other thing they discussed as well is that this study only took place in a very, very small area in Italy in one location, meaning that there may have just been limited heterogeneity in terms of different age groups or different demographic populations and so on and so forth. But in terms of application to clinical practice, I think you did well discussing it there. Just about 2% of all asymptomatic athletes, which is important to understand, had a positive cardiovascular history. So about 2 in 100, which is certainly, I think, relevant enough to continue to look into this. Like you said, history and physical exam frequently are not enough to diagnose these individuals. The history and physical exam only accounted for about 30% of the diagnostics, meaning the resting 12-lead ECG and the stress testing really did the vast majority of the diagnostics. And lastly, this screening works. All of these individuals who tested positive for a cardiovascular disease, I should say, none of them ever underwent sudden cardiac death, meaning that the study found the people that they were supposed to find and then potentially saved their life by either preventing them temporarily or permanently from participating in sports based on the condition and the medical treatment required.
Definitely. I think the other thing to piggyback off of that is the intent of this article was the relation to screening for potential risk factors involvement in sports. But I think we talked about the age profile being 7 to 18 years old. These are people where they may quit playing competitive sports at 18 years old. They may never play it again, but just to be made aware that they have some sort of cardiac risk factor early on in their life puts them in the driver's seat moving forward to take control for the rest of their life. And I think, there's a lot of times where people find different internal medicine related issues through athletics. And I think, you never want people to find out that they have something wrong with them. But it's better to know that early on than to find out in an adverse way later on down the road. So,
yeah, exactly.
Cool. Thank you very much, Christian, for getting this article out to us. I thought it was pretty interesting. I thought it was a good article as well. We got one more time where you will be on the show with us from a research review standpoint. And for people listening, don't forget that we will also have Dr. Bami Adu, our other sports resident, on here doing his research review for pre-participation screening as well. So thanks for listening. And if you have any questions or want to deep dive further, do not hesitate to reach out to myself or Christian Huckfeldt regarding this article. Thank you.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.